Hello, everyone. Um, my name is Swaran Singh. I'm a professor of psychiatry at Warwick University in the UK. And I'm grateful for this opportunity to speak to you. I'm sorry I can't be there personally. The only time I was in Lahore was for 3 days, and I fell in love with the city. And I really do want to visit it again and see it more fully. Um, but this wasn't the opportunity, and I'm sorry about that. And I'm grateful to the scientific committee for asking me to speak about early intervention in psychosis and whether this is a realistic option in resource poor settings. I thought what I'd do is to take you through a whistle stop history of early intervention, primarily in the UK. Give you some key points about what the phrase means and what is the evidence base for different meanings of the term early intervention, and then show you some emerging evidence from some of my projects where we are trying to apply the principles of early intervention in resource poor settings. You can see my email address here, s.p.singh@warwick.ac.uk. I'll take you through a lot of evidence, not so much data, but if you want any papers, anything that I say that you want the evidence for, please write to me directly. Okay, so let's start. Why is first episode of psychosis important? When I came to the UK in 1990, 31 years ago, the mean duration of untreated psychosis from the time that people developed psychotic symptoms to getting effective treatment was about 18 months to 2 years. We were involved in a number of epidemiological studies in Nottingham in the 90s, where we made some very interesting observations from the data. One key observation from long-term studies of first episode psychosis outcome was that you could predict long-term outcomes of psychosis from short-term outcomes. So we had a cohort from the WHO DOSMED study, which had been followed up at 12 years. People with first episode psychosis who were doing badly at 2 years after onset were doing badly 12 years after onset of psychosis. Conversely, those who were doing well at 2 years were doing well at 12 years. We also did a series of studies on the outcomes of first episode psychosis in the first 3 years. It was very clear that the disability that results from psychosis actually sets in very early. In fact, one of our studies we found that symptoms appear later, positive psychotic symptoms appear later, disability appears first. People lose their social networks. They have academic decline, they have vocational decline, they become withdrawn, they stop going out or communicating with others well before they start hearing voices. And so this is called the disability symptom gap in first episode psychosis. So by the time people are frankly psychotic, the evidence now is that it is already too late. We have very good treatments for positive psychotic symptoms, but those treatments don't shift the disability in first episode psychosis, because the disability in first episode psychosis is from a mixture of negative symptoms, mood symptoms, and as we understand increasingly, from cognitive dysfunction. We also found that repeated relapses are more likely to occur in the first 5 years, poor outcomes like suicide or homicide, or adverse events, uh, revolving door pattern of admission and readmission, sense of entrapment and pessimism, all of these are set in the first 3 to 5 years. A colleague of mine, Max Birchwood, wrote a very important paper in the late 90s saying that the early years of psychosis were a critical period. The paper is called the critical period hypothesis of schizophrenia. And Max argued that if you wanted to make a difference to the outcomes of first episode psychosis, you had to intervene in the early years. We were also involved in a large study which was looking at the outcome of first episode psychosis since the introduction of community care, the closure of the long stay hospitals. And we found to our surprise that outcomes of psychosis had not improved despite the enormous investment and effort that had gone into community care. And to our surprise, on some measures, disability seemed to have worsened. Around this time, this is late 1990s, early 2000, several groups around the world started thinking about setting up specialist early intervention services to see if these would make a difference. I set up the first early intervention service in London, NHS funded one. Max was already running a service in Birmingham. Pat McGorry started a service in Australia. Ashok Malla started a service in London, Ontario, Canada. And Merete Nordentoft started a service in Copenhagen. Some of these were trials of early intervention. Now, the term early intervention has three meanings. And I tried to illustrate that with this famous series of paintings by Louis Wayne, who developed schizophrenia and was in Bethlehem Hospital. And as he became more and more psychotic and paranoid, the paintings of cats that he used to draw, the cats became more bizarre. And you can see the eyes getting bigger. So where in the development of this illness do we call early intervention? There are three meanings. The first is early intervention in psychosis means those who have developed the first episode psychosis should get the best possible care as soon as possible. The second meaning of early intervention is early detection, which is people who are in the community who have developed psychotic symptoms or are psychotic but are not seeking help. We should go out and look for them. And the third, which is the most contentious and interesting area in psychiatry right now, is prodromal or pre-psychotic intervention. Can we intervene before people become psychotic and prevent the emergence of psychosis? So these are three different meanings of the term. Quite often when people argue about early intervention, they say it works or it doesn't work. They don't clarify and specify which bit of early intervention they are talking about, because these have different strengths of evidence. The strongest evidence is for the first one. Trials everywhere have shown that as compared to generic community mental health teams, specialist early intervention teams improve outcomes of psychosis in positive symptoms, negative symptoms, and functioning domains, and that it's cost effective. So I'll take you through these. I must say before I get to the evidence, what happened was that when I was setting up the service in London, we did a series of workshop and papers on how much would it cost to set up early intervention services. Again, I'm happy to send you copies of these papers if you want. And we created a model of what an ideal service would look like. So an ideal service would have an early detection team, a prodrome clinic, and a community treatment program. with a specialist early intervention inpatient care service. Now, it was not possible to set up all of these at the same time. So England chose this model. The specialist team with multidisciplinary professionals working together to provide best possible care for young people with emerging psychotic symptoms. The evidence for this is now fairly robust. Wherever a trial has been done of an early intervention service versus a non-specialist team intervention, early intervention services improve outcomes. And interestingly, they save money for the system. So in England, every young person who comes to an early intervention service, as compared to going to a community mental health team, saves the NHS about £5,000 a year. If you project that to everyone getting early intervention services, that's a massive saving for the NHS. So starting from 2004, as services expanded, by 2010, everyone in England was getting specialist early intervention care, and we carry on doing that, and we do it very well. So remember, I told you that the duration of untreated psychosis was 18 months to 2 years before we started this work. It is now 3 months. We have the shortest duration of untreated psychosis in the world in England, and we are trying to reduce it to 2 weeks. So as soon as people become ill, they get the best possible care. So early intervention as providing best possible care to young people with first episode psychosis is conclusively a good thing. One of the other successes of early intervention is that we were able to get young people back into education or work. Now, that's a huge problem. Academic decline and dropping out of work is a massive cost to individuals, to families, to society. And this is one of the trials we did, where we showed that having specialist vocational interventions as part of early intervention increased the proportion of people who returned to training or education or work. So that was another big success. In 2012, a commission was formed called the Schizophrenia Commission, chaired by Professor Sir Robin Murray. That this is a 2012 report. There's an update on it in 2017. And they looked at all of the data for schizophrenia interventions. And this is what they concluded. Early intervention is crucial to improving outcomes. The Commission's view is that early intervention in psychosis has been the most positive development in mental health services since the beginning of community care. So that's not me telling you, that's the evidence, that's the data, showing that it's been an enormous positive reform in services, at least in the Western world. What about the other two forms of early intervention? One is prodromal intervention. So this is looking at young people with high risk of developing psychosis, either because they've got a family history and have started having a decline in functioning, or because they have emerging psychotic-like symptoms. There have been a number of trials of medication, low-dose antipsychotics, of cognitive behavior therapy, of social recovery therapies, and in a variety of settings, in America, in Europe, in Britain, in Australia. And the evidence is, let me tell you what the controversy is, and then I'll tell you what the evidence is. So some people say that this is not really needed, and it's a waste of resources. So on the one side are people who believe that you have no good screening tests for identifying who will become psychotic. You have no effective preventive strategy, and you will end up treating those who are false positive, who will never become psychotic, or those who will have an acute and transient psychotic episode who don't need long-term treatment. and you will unnecessarily stigmatize people that they are going to develop psychosis. CALMS is a term used for those who are called prodromal, clinical assessment of at-risk mental states. And people who don't like the idea of prodromal intervention say that this is a highly selected sample in tertiary ivory tower academic um, universities and institutes. It has no relevance to general psychiatric practice. On the other side are people like Pat McGorry, or would say me, who believe that this is a help-seeking population. We haven't. They've already come to services. They're already symptomatic. They already have symptoms. You can't tell them go away, become psychotic, and then come back. Then we will treat you. We are not talking about universal prevention. We are not saying let's put antipsychotics in the water supply of the city. We are using low-dose antipsychotics or safe and efficacious interventions, psychotherapies, to try and prevent the emergence of psychosis. There is evidence that you can prevent the emergence of psychosis, but not in a huge group. But about a third of people who get prodromal intervention have no transition to psychosis. If you intervene, the intervention modality seems to be not differential, by which I mean some form of psychotherapies work, low-dose antipsychotics also work. Thomas McGlashan said many years ago at a conference that the evidence for prodromal interventions is in a state of equipoise. Equipoise means balanced uncertainty. You can argue either side. We are still in that same place. We have made a lot of new discoveries. We have found that people who go from pre-psychotic to developing full-blown psychosis have brain changes, progressive brain changes. So the idea that having psychosis may be toxic for the brain is borne out by some neurobiological evidence. So all the more reason to intervene early. But we can't claim to truly prevent psychosis at this stage or truly identify with high degree of sensitivity and specificity who is going to become psychotic. So this is an evolving area. The third form of early intervention is early detection. So there was a trial in Norway called the TIP study, which showed that if you had an early detection strategy where people were allowed to seek help as soon as possible and were seen quite promptly, their outcomes were better than if you didn't have early detection. We did that in Birmingham. This on the right side here is a poster that appeared on billboards and backs of buses. We did it in one area and not in another, and we found that you could reduce duration of untreated psychosis by a public education campaign. However, this hasn't worked everywhere. So when they tried the same model in Ontario, in Canada, they did not find any difference in duration of untreated psychosis. Now, that may be because the service structures are very different. So again, here, this form of early intervention, we need to keep an open mind. So 20 years on, early intervention is now considered a good thing. And this is a paper from Nature in 2011 of grand challenges in global mental health. And it says here, advanced prevention and implementation of early intervention. This is talking about all mental disorders. I won't go into that, extending early intervention to other non-psychotic disorders. That's a very big area in itself. I'm going to stick to early intervention in psychosis. Now, can we apply early intervention in psychosis in resource-poor settings? The reality of resource-poor settings is this. Many people with psychosis are untreated, chained, locked up in a terrible, terrible state. I'm sorry, the phone started ringing. This here is a tragedy that occurred in India in a place called Erwadi in Tamil Nadu. Erwadi is the dargah of a Muslim saint from Arabia who brought um, Islam to India. Now, over 1,000 years, this site has become a place of pilgrimage where people bring the mentally ill to for treatment. And they were one of the buildings there caught fire in 2004, and many people died because they were chained to their beds. And you can see these are the bodies. So the reality of psychosis in low and middle income countries is quite dismal. And in parts of sub-Saharan Africa, things are really poor. We've done a study in the only study of mental health care in Somaliland. There are 2 psychiatrists in Somaliland. This is the only psychiatric facility. There is no inpatient care. And 1 in 10 households has someone in chains because they've got a psychotic relative or someone with learning disability or sometimes epilepsy. Malawi has 1 psychiatrist. So you can't really take the specialist early intervention model and put millions of pounds on developing early intervention teams when basic psychiatric care is missing. So should we give up on it? Well, not really. We've done some studies to show that duration of untreated psychosis is quite large in low and middle income countries. It ranges from 30 weeks to 225 weeks. Now that's about, work out how many years that is, 5 years. And many people will seek help from traditional healers as the first or the only source of contact. So based on those findings, I'm going to now suggest to you in the next 10 minutes or so how to do early intervention in low and middle income countries. So we can do 4 things. One is contextualize care in a culturally appropriate manner. Second, make care protocol driven so everybody gets similar standard of care. Use the power of digital technologies and use the strength of low and middle income countries. So we have a lot of strength. When people in the West look at India or Pakistan or Bangladesh, they see deficits. What they don't see is the strengths of the country or the system. And I'm going to focus on some of that. This is a paper I did with Professor Suhail many years ago when she was at Lahore GC University. We showed that the concept of emotional over-involvement is simply not valid in a context like Pakistan. We can't use the same measure. So when we talk about behavioral family interventions, the whole concept of emotional over-involvement is very different, and we have to think about it quite differently. In Pakistan or in India, people will give up their jobs to look after their relatives. In England, if a mother starts crying, describing her son's illness, the nurses and doctors will say, oh, very high expressed emotion, toxic family. We don't realize the strength of the family-based system and how much good it does in psychosis. And I'll show you some recent evidence for that. We've been doing a series of studies. We are doing a trial of, just completed a trial of improving care in a 170-year-old British institution and developing models of lay workers. This is work done by Ashok Malla and his team in Kashmir conflict area, whether mental health care workers can be trained in providing basic care. This is the project that we are running right now. It's going to come to an end in this January next year. What we did was we created a protocol for first episode psychosis, which we implemented in a clinical service, All India Institute of Medical Sciences in Delhi, and a community non-governmental organization, SCARF, in Chennai. And we are doing a detailed analysis of pathways to care. We are using mobile technologies to ensure continuity of care, and we are doing early detection. And across these, we are also doing implementation science and health economics. These are two things that are rarely done in settings like India or Pakistan. So I'm going to give you very briefly preliminary findings. COVID has interrupted our project. I'm going to tell you what we've learned so far. And these are various publications that have already come out. So if you take outcomes, what we find is that regardless of the duration of untreated psychosis, people in low and middle income countries have very rapid response to antipsychotics. Really remarkable response, not just to positive symptoms, but also negative symptoms. Most people will show very good recovery within 3 months, and by 6 months, you can predict this person is going to do well. So there isn't the slide and the repeated relapse that you see in the West, primarily because families are involved and there are very high levels of engagement. Where families are not involved, of course, people will have very poor outcomes. They'll become vagabonds. They'll go into hospitals for long time. They'll become abandoned by the families. But where families stay involved, the protocol-based first episode psychosis care model works very well in a low-income country. We've got an app called Suction, which has information. So what happens in a country like India, and I suppose it happens in Pakistan, people come from very far away. A few family members come along, they lose income, they lose money. They can't stay for ongoing treatment. They have crisis care, they go back 200 miles away, and then they stop receiving care. We are using mobile technology to deliver care so that people don't have to travel. We've done a large school-based study. This is data from 13,000 young people, where from the ages of 14 to 18, where we've screened for depression, anxiety, and psychotic-like experiences. Look at this figure here. 12% of young people are scoring moderate to severe on all three scales. So that's 1 in 10, slightly more than 1 in 10. Many of these young people are at risk of ongoing psychopathology. So again, they may not all become psychotic, but they clearly are in distress and possibly with some disability. Our health economic data, the first time being done in LMIC, is showing that it is an enormously expensive illness to have. Even where treatment is free in a government hospital, families lose a lot of money just trying to get that free care. So even free care is unaffordable. And we are doing implementation science work where we are trying to see what are the barriers to expanding. We've done it in 2 centers in a research plan. We want to now extend it across. I'm finishing now. We've also been doing public awareness. We made a movie on command hallucinations called Command and I Shall Obey You. It's in Hindi. And I'm very pleased to say that the actor who played the main character won the Best Actor Award in India's most prestigious acting award, Dada Saheb Phalke Film and TV Award. So we are trying to extend our public awareness campaign. We are doing a very large study. I don't have space to go through, but we are identifying enormous numbers of untreated people with serious mental disorders. This community study identified 12,000 people in 9,000 households with severe mental disorder, untreated. And finally, we are going to start this new project where we are going to work with faith healers in sub-Saharan Africa and the Indian subcontinent, and training them to identify schizophrenia and psychosis and serious bipolar disorders and send them for biomedical care. So Early intervention definitely has delivered on its promise in the West. And we feel that you can take the principles of early intervention and apply them in low and middle income countries. We are very grateful to Afzal Javed, Dr. Javed, who's the president of the World Psychiatry Association. And he set up a special group on early intervention in low and middle income countries. And I chair that group. And I hope that in 2 or 3 years, I'll come to Lahore to another conference and show you how much we have achieved in that period. So thank you very much. I'm very sorry I'm not with you. Enjoy the rest of your conference and take care. Bye-bye.